Hello everyone, how is it going? So today we're going to talk about the state of coma, or what is this comatose state we are talking about today. So this is going to be a lecture based on a few things that we're going to discuss. So there's going to be definition of coma, because I always believe that once you start with anything, the definition goes a long way into explaining what it is about and how do we think about the topic at present, for instance. So, and then we talk about the pathogenesis of coma, or what is basically causing this state in a person, and how we assess and manage. And then there will be a few questions intervening in between, which we will discuss as well. Okay. So defining coma. So basically, it is a reduced state of alertness, which is differentiated from syncope by being sustained and from sleep by being easily reversed. What does that mean? It's a comatose state. It's an obtunded state, another common layman term for it, in which the person basically is not able to wake up for an extended time period. Because obviously, if it is syncope, then the patient goes to sleep or loses consciousness and then comes back again. And then also, just like that, if it was sleep, then the patient is arousable easily. Whereas in a comatose state, you won't be able to, no matter how hard you try. By giving a stimulus of pain, verbal commands, patient does not wake up. So that is coma in short. And there is another term that is very often that comes up in hospital rounds, during the hospital, or when you're studying, which is delirium. How do you differentiate delirium from coma? It's a sometimes confusing term. Delirium is another state in which there is a reduced attentiveness, which is seen in a patient who is usually admitted with an altered thought contents, sometimes the patient being hyperactive as well. You won't find the patient to be totally out of it, or with eyes closed, who has lost consciousness. But the patient would rather be alert, but he would be confused, he will be agitated, and he will be talking irrelevantly. And they usually in delirium situation is another cause, something identifiable that is causing the patient to become agitated or inattentive. But you can be confused sometimes even with delirium, because you might catch the patient in a situation when he or she is in the state of decreased arousal. So on face value, you might say, "Oh well, the patient is comatose." Rather, actually, he is not. So that might be the case as well, because delirium is also a state of fluctuation cognition. The patient might sometimes be alert, and other times might be just drowsy, difficult to arouse. But you always differentiate it from coma in terms that the comatose state will be extended and the patient will not wake up at all. Okay. So these two things are important to distinguish both from each other. Now moving on to the pathogenesis of coma. Now you can see here in the diagram here I have shown very simple diagram. This is the brain, the cerebrum. And you can see here these are the ventricles, and if you come down, then this is the brain stem. Now the brainstem consists of three parts, and we will talk about it in detail, but basically what I'm trying to show here is this portion of the brain stem. These are a network of fibers, the pink part that I'm referring to, or neurons, ganglions, cell bodies basically, which are known as the reticular activating system, or RAS. What is the function of this system? It is the wakefulness center, is the alertness center of the body, which is very important if it is active to keep the patient awake and alert. Now it has, as you can see here, connections throughout the brain. It has connections with the cerebrum, which is the important awakeness, alertness center of the CNS, or the central nervous system. It has also connections with the thalamus. This is also a very important part of patient's awakeness and alertness, and the basal ganglia, as well as the cerebellum. Okay, so any lesion basically that might affect these pathways anywhere along here significantly will cause the patient to lose alertness, to lose awareness. So similarly, if you have a patient who gets a stroke, then they will obviously have decreased alertness, or they can go into a comatose state. But as you can see, there are so many connections here. Obviously, the patient will go into a comatose state if these connections are significantly severed or impaired. So, a large stroke or a large bleed or a structural abnormality like a tumor will cause it. It can even happen, obviously, here. So even here, it can affect the alertness of the patient. But obviously, as you can see here, the system itself is present here, and it's a very small space. So even if you get a very small stroke in this area, that is a brainstem, it is enough to totally obliterate this area and cause significant damage to the alertness center. And so the patient will become comatose very easily with even the smallest of lesions in the brainstem rather than big ones here in the cerebrum. Okay. Further on with the pathogenesis of the coma, as I have explained, there can be either a structural lesion that affects the cerebral cortex. Now, here you can see the cerebral cortex very easily shown. A lesion that affects the brainstem, as I said, can also affect that system, the RAS system. And since the RAS reaches the level of the medulla, it can also be affected there. So, as you can see here, this is the brainstem, and here is the medulla. So, the medullary reticular formation, it can also be affected. We'll talk about these things detailed later on. But basically, what I'm trying to explain to you is a lesion here, a lesion here, a lesion here, anywhere, or even here, can cause decreased alertness. Now, moving on, we can divide the causes of coma based on where the lesion is in the brain into supratentorial and infratentorial structural causes. But there are other causes as well. These might not be structural causes, so they are based on either diffuse causes or metabolic disorders, etiology. So we'll discuss those as well. Now, diffuse causes can cause global disruption of the reticular activating system. So because it's not localized or restricted to an area, the entire RAS can be affected in such causes. And hence, centers of the awareness leading to a comatose state will happen. Okay, just a simple quote. Just for the comatose patients that you see on daily rounds, especially in ICU, they may forget what you said, but they will never forget how you made them feel. So remember that these patients are human. And when you're examining them, you put them through a lot of pain to try to wake them up. Always try to be considerate, always try to be conversive to them. You need to let them know that you're sorry, because they might wake up the next day, and even if they don't, they'll remember what you did to them. And as the story suggests, sometimes some patients who have been comatose and later wake up, they do remember the patients, they remember the names of those physicians, particularly, who were kind to them and those who were not. So remember that. Just a small food for thought.